Dr. Moriarty, you can turn your camera off. Thank you.
Hello, and welcome to this evening's RLI Power Hour webinar titled Stories of Leadership, Initiatives, and Impact. My name is Dr. Jennifer Nathan, and I'm co-moderating this evening's session with Dr. Bob Pyatt as we are co-chairs for the RLI Power Hour webinar series. Before we get started, there are just a few logistical items that we want to run through with you so that you know how to better participate in this evening's event. So when you joined through the Zoom platform. At the very bottom of your Zoom window is the Zoom control panel. I'm circling it here, it looks like this. And there are two icons on here we want to draw your attention to. The first is the chat icon. The chat icon you would use if you're having any sort of technical issue. So click on the chat icon, up comes the chat window, type in your technical concern, hit send, and then our staff will be reaching out to you to help you resolve the issue. The second icon we want to draw your attention to is the Q&A icon. The Q&A icon is what you would use to submit questions to our speakers this evening. You're welcome to submit questions at any point during the webinar. However, they will be collected and not addressed until we get to the dedicated Q&A session at the very end. One other additional item we want to let you know about is that this is a recorded webinar, and that also includes the Q&A session and the participant questions at the end. So I'm now going to turn things over to Dr. Pyatt to introduce this evening's faculty. Dr. Pyatt.
Thank you, Jen. We have quite a faculty lineup for everybody tonight. These are award-winning faculty, and they're going to share with you their great stories of leadership and their impact. And hopefully you can all learn something valuable from their many stories tonight. Dr. Ryan Doon is the president of Advanced Radiology Services in Michigan, and he is a pediatric radiologist. His group, the private practice group, Advanced Radiology Services, is one of the largest private practice groups in the United States. Dr. Achintya Maulik is the CEO of CarePoint Health System, which is a clinical business and thought leader in the healthcare industry with an international recognition and following. He is a cardiovascular surgeon by training with expertise in congenital as well as acquired heart disease. His special interest and expertise is in low birth weight complex neonatal heart surgery. He has hospital leadership experience for over 20 years, having started one of the largest healthcare systems in the world, the Fortis Healthcare. Dr. Maulik has traveled and worked with strong administrative and clinical teams worldwide, and many of his team members are C-suite leaders in the United States, Europe, the Middle East, and Southeast Asia. Dr. Vivek Mason is system chairman of radiology at CarePoint Health, a regional healthcare system of 3 hospitals in northern New Jersey. During his 10 years as chairman, Dr. Mason has developed a women's health pavilion. He's implemented various screening programs, including a lung screening program, developed a comprehensive radiology quality dashboard, implemented several AI initiatives, participated in several grants with the TCPI initiative, that's the Transforming Clinical Practice Initiative of CMS, and he's overseen macro and MIPS initiatives in his healthcare system. Dr. Mason graduated from Brown University School of Medicine, where he currently serves on the board of directors. Following Brown, he completed a residency at New York Presbyterian Weill Cornell. He received specialty fellowship training in MSK, musculoskeletal radiology, at New York Presbyterian Columbia. He has received leadership training throughout his career at the Harvard Business School online and at the RLI, the Radiology Leadership Institute. Lastly, we have Dr. Andy Moriarty. Dr. Moriarty received his undergraduate degree in biology and human physiology from Northern Michigan University and his medical degree from Wayne State University. He completed his residency in diagnostic radiology at Henry Ford Hospital and did a fellowship in abdominal imaging and cross-sectional interventional radiology at UCLA Health System in Los Angeles. Dr. Moriarty is interested in healthcare policy and economics and served as the chair of the 2014 to 2015 ACR Resident and Fellow Section. He has been published in numerous journals, and his awards include the RSNA North American Röntgen Resident Research Award, as well as the Dr. Karen Stuck Memorial Award for Outstanding Research by a Senior Resident. He also has received awards at the RLI Institute annual event with the Scholarship Award, and also Musculoskeletal Division Best Case for the AIRP, the American Institute for Radiologic Pathology. Dr. Moriarty is board certified by the American Board of Radiology, and his professional memberships include the ACR, the Society of Abdominal Radiology, and the Michigan State Medical Society. It's quite a pleasure to have these four outstanding faculty with us this evening, and I'll turn the program over now to Dr. Mason. Thank you.
Thank you, Bob. Firstly, I would like to congratulate the RLI on its 10th anniversary. This is an important organization with a mission that fills a critical void in our specialty. Sorry, let me begin again. So firstly, I'd like to congratulate the RLI on its 10th anniversary. So in regards to my own journey, the RLI has been an integral resource that I have relied on for the last 10 years. When I stepped into my role 10 years ago as system chairman of radiology of this newly formed regional health system of 3 community hospitals in northern New Jersey, I had a strong clinical foundation, but what I didn't have was any formal leadership or training. That's when I turned to the resources of the RLI and the ACR to fill that void. This was radiology-specific information that I could use immediately and purposefully on a day-to-day basis, as well as for important projects and assignment. We are very fortunate as radiologists to have access to this treasure trove of resources. Today, I wanted to quickly go over how I utilized lessons learned at the RLI to help make an impact in my community. I also am looking forward to hearing about Dr. Moriarty's very impressive initiative. So radiologists, we are the doctor's doctor. We are the major conduit of the modern hospital. But oftentimes we're forgotten in the shadows and dark rooms, grinding away in our work lists. How do we show value outside of the reading room? How do we deliver impact at a community level? What I want to discuss today are 4 key steps that I believe deliver impact at a community level. These are lessons that I learned at the RLI, and I wanted to kind of walk through how some of these initiatives can be impacted at a greater level. The first is to develop a mission statement. There's a very good book, Simon Sinek's Start With Why. What is the why of the project you're doing? The second is stakeholder buy-in. The third is understanding financials. And the fourth is public health outreach. These were all webinars, courses taught at the RLI, so these are accessible to people who want to further explore these, and I've given the names of the lecturers for these courses. So the mission statement, start with why. What is the purpose? What is the reason of what you're doing? Be broad and aspirational. This is the time to get the bird's eye view. Don't get bogged in small details. My mission statement in developing our pavilion was to develop a state-of-the-art women's health pavilion that will directly address barriers to care and systemic bias in our local community. In this statement, there are 3 components. First, we wanted to develop a state-of-the-art women's center. We wanted top of the line, and we did not want to spare any expense on technology, quality, or comfort. The financials would come later. We wanted to deliver the absolute best to our patients. Secondly, we chose the word pavilion and not center, as we wanted this to be multidisciplinary. we wanted to leverage on a lot of the resources that we were putting into the system in surgery, gynecology, oncology, IR. So we wanted to make sure that this was a center that would incorporate many subspecialties. Finally, we wanted to have a purpose. By assigning it a purpose, we felt that it could deliver greater impact. And specifically in our community, we wanted to address access to care and systemic bias that exists within our community. So the problem. So we have a very unique healthcare system in New Jersey. It's a two-tier system of healthcare. On one side, you have an affluent suburban population with an excellent payer mix. On the other, you have a densely urban population of community hospitals and academic centers with a suboptimal payer mix. Our center is located in Jersey City, New Jersey, which has a population of about 300,000 people. I was born and raised in Jersey City and now work here. So for me, this is truly my community hospital. This is a hospital where I wanted to make a difference because I have such deep ties and deep roots to this community. The demographic breakdowns in Jersey City are approximately 26% Asian, 24% white, 24% Black, 24% Hispanic, and 2% others. We have a high undocumented worker population of about 13% or about 40,000 people. So in our communities, there's a lot of barriers to care for our patients. Many of our patients can't afford to lose a day's wages when they come to work. Many of the subspecialized services that they need are not offered locally, and as a result, they have to travel great distances. In building our center and in many other initiatives that Dr. Molik, our CEO, will discuss following me, we really look at how we can overcome these access to care issues for our patient population. In developing any initiative, there has to be buy-in. This can't be done in a vacuum. And multiple stakeholders need to be involved and be on board in order to have a successful venture. As far as the corporate team, you need to articulate your vision, know your numbers, and emphasize downstream revenue. I can recollect my first meeting with my CEO, Dr. Molik, and his corporate team in their executive offices in Hoboken. This was my first meeting with the CEO. This project had been proposed to prior administrations and on several occasions was rejected, primarily for lack of financial resources and lack of overall vision. Dr. Molik was very supportive of the endeavor and understood as a physician the value and benefits that such a project would have for the community. He told me, make it happen. With his approval, we were able to push forward on the additional steps and completed the project in less than a year. As far as the medical staff and our targeting referring physicians, we needed to understand our target audience, and specifically with our center, gynecology, oncology, surgery, IR. There needs to be vested interest on their end, and we need to discuss how we can benefit their practice. Currently at our system, we're in the midst of expansion of breast, oncological, and surgical service lines. So this project came at a fortuitous time where we could leverage the current positive growth trajectory, building relationships and establishing relationships with the breast program, which could ultimately enhance downstream revenue with breast surgeries, with the oncology service line, building up revenue with radiation oncology, with infusion, building up the interventional service lines for uterine fibroid embolizations. These are the kind of initiatives that we wanted to bring at a greater impact for our hospital, which would ultimately benefit our bottom line, but also, and we felt just as importantly, to add value to our patients in bringing access to care that they would not otherwise have in our region. Ultimately, the project needs to make financial sense. You need to understand the basics of financial statements as well as project costs to be able to deliver your message effectively. Our goal is to be sustainable with additional downstream sources of revenue with our payer mix. This continues to be a challenge, but our volume has grown, and coupled with the overall benefits to the community, this initiative, by any measure, has been a success. I was actually sitting with our CEO today, and we were looking at robotic surgery and some of the revenue challenges that exist there. But we as an institution for example, with robotic surgery, are committed to giving the best resources and technology to our consumer base as possible. And again, despite many financial challenges. When it comes to political outreach, big issues can't be addressed in a vacuum. You need to sell the importance of your project. And you need the support and help of the community as well as political leaders. We live in northern New Jersey, and where we reside, the support and aid of the government is essential for the continuation of vital services in centers like ours. Unfortunately, the finances are complicated, they're messy, and oftentimes frustrating. Without some government support, urban hospitals like ours wouldn't be able to survive. Getting buy-in from the mayor, from the governor, from councilmen, from state senators, this cannot be understated, is critical to the survival of hospital systems like ours. Finally, I wanted to end on this slide. The second portion is at our grand opening. We had our CMO, CEO, we had the mayor, the state senator, and this was a very, very important day for us because even though it was a short time when we completed the project, the impact that we thought it had on the community was far greater. And we're very proud of that achievement. On the left is Laverne. Laverne's mother and sister died of breast and ovarian cancer, respectively. I was in my office reading cases one day, and I was asked by my manager that one of our patients wanted to talk to us. When I went to the room, Laverne broke down and started crying. She was so touched by our project, the impact it had had on her and those around her. She personally donated 100 handmade goodie bags of inspiration and hope to patients in the community. Laverne is our why. She is the impact that we can make to the lives of those in our community. And that's why we offer the care we do, always putting the patient front and center. In conclusion, this was the story of our impact in my community. I hope this story can inspire others, particularly newly emerging leaders, to be impactful change makers in whatever way they can. Thank you.
Is everyone ready for my segment?
Yes, go ahead.
Yes.
Thank you, Vivek, Dr. Mason. You pretty much summed up everything. And for full disclosure, the picture of mine is from 2012. Having said that, I really am appreciative of Radiology Leadership Initiative and American College of Radiology for having invited me. So when Vivek asked me to come for this seminar and for webinar, this was one of the three strange meetings I've been called for. And being a congenital heart surgeon, I'm not used to speaking in non-cardiac meetings. Recently in my Becker's podcast, I told them that I'm primarily a surgeon and an accidental CEO. So I took over these three community hospitals in 2020, just as COVID came onto our shores. So all the electives were stopped and we were thrown in the midst of a pandemic. The three webinars that I've spoken on, this is the third one. One was a thoracic fireside chat on life of thoracic surgeons after COVID. The second was a talk on status of hospitals during COVID and pre-COVID in the American Bankruptcy Institute, because the large number of hospitals going through bankruptcy and insolvency. And now this. So there's a common thread that runs through all this. And central to this was my talk on how to manage stress and how to manage stress of physicians, and also how to manage finances within institutions, at the same time providing quality care to the communities. So the three hospitals along the Hudson County serve, as Vivek said, Dr. Mason said, serve some of the poorest people in northern New Jersey. We have an 80% African American and Hispanic population, and 60% underinsured. So coming into a leadership role into this healthcare system, I was not aware of the impact that a payer mix can have on the survival of our institution. During COVID, of course, a lot of institutions got sufficient funds from the state. And we went through that blindly, not even thinking about healthcare costs and finances at that time. We were too busy as a frontline institution, as a safety net hospital, that facing a deluge of COVID patients. And after that, we are suffering from a huge number of agency nursing causing a severe dent to the organization. So two things that can happen to a community hospital. Either they can shrink and become a kind of a center for only taking care of indigent patients and slowly fade away, depending on government doles and largesse. Or, as we decided, that the community hospital, because of COVID and because of decentralization of health, should become an advanced care provider. So when Dr. Mason came to me and told me that, Dr. Maulik, I want to build a women's pavilion. And I said, of course, don't we have one already? He said, no, we don't have one. And we need to provide for this densely populated part of America. We don't have any women's center. Not knowing very much about costs and the finances involved, I said, come on, make it happen. And it didn't cost us that much. We did get it started. He did a phenomenal job getting it up, and it's very well appreciated. But as we started getting more and more initiatives, we realized the burden of developing advanced imaging centers and tertiary care can have a major financial impact on healthcare systems. So how do we tackle these challenges? One way to tackle is to create certain centers of excellence. Like we have a women's pavilion in Christ Hospital. We are developing an orthopedic center for spine and joint in Hoboken Hospital. And we are developing a cardiology which is ongoing. It's already there, but we're enhancing them in each hospital. So we are necessarily not replicating each of these in each of these community hospitals. At the same time, we are building specialties so patients do not have to leave this region. So what has happened is Manhattan, which used to get a lot of our patients from our region before COVID, now have chosen to stay back, and not out of choice, out of lack of choice, because of decreased mobility. I don't know what's going on in major metropolis. So what do we do? So we have taken this opportunity to create local healthcare advances. So we have a ton of patients now, instead of moving to New York and other places, are coming and are being taken care by the community hospitals right here at CarePoint Health. However, because of the healthcare changes that have happened in the last 10 to 12 years, there have been major consolidation. And this major consolidation has led to creation of some kind of a healthcare desert in areas. And this has happened in areas which most need community healthcare facilities. And as Vivek said, it's imperative that we have these community healthcare facilities to provide optimal care to the people who need it most. And this can only happen by support from the state and the federal government. I mean, unfortunately, the cloud remains with the biggest systems with the most money. But that doesn't stop people like us, we have a fairly decent sized system, to ask. So what, as Vivek came and asked me, and he asked me that, Dr. Malik, can I start something? We have been pretty aggressive in going to the local authorities, going to the governor, going to assembly people to ask for help. The second thing what we have done in making advances is, instead of developing all these programs de novo, we have affiliated with major healthcare systems. So in the last 2.5 years since I've taken over, we were the first community hospital to start an ECMO program. We started in 19 days. We signed up with Columbia University at Presbyterian. They provide us colorectal and oncological services to the community. We also have partnership with Rothman Orthopedic Institute, who are coming in with 7 surgeons to provide us advanced spine, joint, hip surgery, and sports medicine. There are other major healthcare systems who have come to us to provide us oncological care. But all this puts a lot of pressure on our imaging services. When I was training, I trained a lot of my time in India and Bombay. The only time I visited the radiology suite was to find out certain results on X-rays and CT scans. And second, because it was all the other rooms were not air conditioned. The CT suite was air conditioned, would go and sit there and talk to our radiology friends. Here, it's been a very rare interaction, and unless Dr. Mason comes to me for some other reason, I do not know what goes on. However, what has happened, and I've realized that we need a lot more automation, because you cannot replicate the same radiological pool in each of these community hospitals, or even within a community hospital center. So as automation comes on and the present power of AI, we already use Viz AI we are the first center in the country using Viz AI and hyperfine MRI to do strokes interpretation and treatment. We have realized that we need more and more automation. We need leadership amongst our radiology team to come up with ideas that can increase automation and decrease the amount of time that we spend on reading these images, as well as decreasing our, instead of increasing our workforce, optimizing the workforce. That should be the ideal terminology. And that is what we're looking forward to do. We are also very open-minded about partnering with other imaging institutions. And I've seen how Dr. Moriarty and others and Dr. Dunn have created their large institutions. We are open to collaborating with them. Dr. Mason is getting Telerad into our system to read mammograms. So we're open to that, because it's impossible during seeing the workforce and the reduction in the number of institutions across the country that provide these services. We're open to teaming up with such institutions. However, in the end, it is very important, as I said, that community hospitals need to be open-minded about providing more care instead of less care. The trend before COVID was that community hospitals will do bare minimum, and all the major care would go to tertiary level hospitals. The thought process is slowly changing. In my point of view, the community hospital will share a large burden of tertiary level care, so that we can provide the care and manage these patients in a local level. The Women's Pavilion is a major example in which Dr. Mason has brought forward a remarkable number of patients, a lot of early treatment and early care. And we continue to develop these kind of initiatives over a period of time. And thank you again for having us here. And please let us know how we can work together in the future.
Dr. Moriarty.
Start my share screen if that's okay. Take over. Yep. Thanks everybody for having me. Like Dr. Mason, I wanted to thank the RLI and congratulate as well on its first 10 years of success. I have been involved in the RLI for a number of years after going to one of the early RLI Summits when it was held in Chicago, actually, and I was an early scholarship recipient there. And I quickly learned that there was a lot of things happening in this sphere that weren't being taught in my clinical education and weren't being a part of sort of the day-to-day clinical focus that we had. And so I thought these are really great programs that are designed by and for radiologists, really giving us information in a radiology specific way as we strive to really deliver patient-centered care, but maintain the physician-led core that is important to all of us. So I think the RLI really helps radiologists to lead radiology. And I'm thankful for all the lessons that I've experienced through the Kickstart Your Career program, the Maximize Your Impact, and numerous on-demand webinars like the one tonight. And so I wanted to say thank you and tell you a little bit about our project. It kind of starts with a little bit of background from our practice, right? I joined ARS a couple of years ago. It was established in 1998 through a merger of the local health hospitals to create one healthcare system. And there was around 20 radiologists at that time. And over the ensuing years, there's been a lot of growth. It's expanded to 220 radiologists and 14 different health systems, all while maintaining its 100% physician ownership. It also has a 100% ownership stake in STARS, the Strategic Advanced Radiology Services, and DRERS platform, which is what we're going to be talking about tonight. A particular focus on teleradiology solutions, having really strong clinical uptime, clinical quality, and maximizing the impact of our distributed radiology platform. The ARS does have a wholly owned 501c3 public charity. We are the sole member, and then a joint venture with Spark Radiology, which we'll talk about just a little bit later on. So our practice is organized by an elected board of governors, which oversees the numerous committees. The clinical leadership committee is one of those. I'm the chair of that, and it interfaces closely with all of our radiology section chiefs in the clinical sections you can see below. Those section members are self-selected when they join the practice, with obviously ongoing continuing medical education requirements and the need for daily staffing. So one of the challenges we had was we were really operating in two different separate silos. We had a very robust platform that was sharing across multiple health systems and really linking up those radiologists across the state. And we had a large tertiary care center that was organized around a strong local presence of radiologists providing sort of 24/7 care in a busy clinical setting. And so as the chair of our clinical leadership committee, I was tasked with helping to combine those two over a relatively short time frame in the history of the practice, and I had to work with the section chiefs. I had a great team in our distributed radiology team, our decision support analysts, and the clinical physicians, as well as engaging the hospital partners. One of the really early lessons from some of the RLI lessons was it's important to make sure you have stakeholder buy-in, as Dr. Messon mentioned. So we took about 12 months, and our group really looked to bring these two systems together. At that time, we were about 2 million exams a year and 200 radiologists, and we wanted to figure out how we could make that all work together. So I'm going to start off right with the successes, right? We had a number of great outcomes of the project, and then I'm going to talk about how these have all kind of unfolded. But of course, it was a busy thing. We did it over about the course of 12 months here. We analyzed everything down to the smallest detail and really created from the ground level up an index of all of the volume and cases coming in. Next, our decision support and scheduling teams met one-on-one with all of the section chiefs as representatives of their radiologists to really figure out what that combined work list and workflow would look like in the future, assigning things like on-site responsibilities, secondary tasks, and then really figuring out how it would all flow together. And then in the final phase, a lot of small details were done, but then we created all of that into some what we call shift responsibility documents to really give the radiologist an insight into what the new workflow would be. And then we created optimized reading radiology work list with a little bit of, I would say they're smart work lists. They're not quite at the at AI level yet that Dr. Mulek was mentioning, but we're getting there. The foundation of all this was really our STARS Data Warehouse team. They have a tremendous amount of data that they collect from different operational systems and hospital data files. They bring that all in, make sure it's organized. It's growing every day. I think the last count I had was 4.7 terabytes. And so that's the clinical side of the data. On the radiologist side, we have a number of data points that we like to collect and refresh. One of them is, we call it time tracker. It looks at non-interpretive activities and administrative activities. It's built into not only a website application, but native iOS and Android apps, as well as being integrated right on the work list so the radiologist has easy access to it. It covers 26 current and growing service specialties and covering 17 different hospitals and ranging from medical director activities, clinical advisors, conferences, technologist protocoling, and everything in between. The next piece of data we need from our physicians was, well, what sections are you in and what are you comfortable reading? And so the team developed a skill set that is collected electronically and fed into the database to help with our ability to schedule staffing. So the backbone of output of that is the clinical volume data. And this is just a very high level look, but what's really interesting about this is the team can take that data and parse it down into really the operational reports that we need all the day. So we get daily reports on a couple of key metrics. We get weekly reports on turnaround times and really forecasting our schedule now. We have quarterly reports that go to the physicians as well as to the practice, and then semi-annual and annual updates that are built into our recurring theme because we know that things keep changing. And this helps us stay on top of not only where we are, but where we want to go. This is a high level view of that data table that shows all of the shifts that went into being created, and then sort of an early volume estimate there on the bottom right. And we'll dive a little bit deeper into that. So the tool actually can sort by every single useful clinical breakout that I can think of, and it has a lot of built-in features that's really fun, where you can change the start shot, the shift times, you can change the reading pace and everything. The end result, of course, if you color it by a rainbow in sections, is you get the breakdown in an hourly estimate, not based on incoming volumes or a guess at what's going on, but what our actual radiologists have told us they want to do in their clinical practice, what subspecialties and what examinations they're comfortable reading, broken down by their self-identified modalities. And we can actually see the needs for the corporation in real time on an hour by hour or even greater basis. But the great thing about this, again, I mentioned, is you can subdivide it into almost anything. We can look at this by specific sections. So here's an example of just the cardiac and cardiology button of that previous graph. Can show you there's not a lot of cardiac MRI being done at 1, 2, 3 in the morning, right? But it gives you an hour by hour need for staffing. We can look at it by procedures. So this is one of our breast mammo shifts, is what is the need for screening mammography compared to procedures or other high-end imaging in the specialty, and where do we best move those radiologists? And the next part about that was, so how do we integrate all of that into creating our daily schedule, right? One of the key outcomes of this project was creating the right organizational structures. So in the CLC, we really try to engage the section chiefs as the representative of their individual section members. They were bringing all this data to us saying, this is where we think that makes the most sense. And then at that level, we had to get buy-in across the specialties so that everything was covered and the areas of overlapping service were really integrated well. Again, I think, as I mentioned earlier, this involved 14 different hospital systems and really did it. So I showed you the graph earlier of what the schedule needs looked like. Well, this is what our clinical section chiefs did, is they built a clinical section around that had overlapping coverage based on the radiologist availability. And it really resulted in improved clinical efficiency for us, greatly increased the amount of subspecialized patient care that we were able to offer, while also opening up new ways that radiologists could partake in what we call alternative tracks to enhance their work-life balance. And we've opened up new scheduling opportunities for radiologists that just weren't available before. And a lot of these tools have sort of gone into modeling future growth and hiring needs that are adaptable across the practice to help give us more information. And so that'll be coming up next. Another key aspect of the project was, well, how do we address the physician challenges when working in that big team and trying to get those diverse perspectives, right? It was going to be a major change to the daily workflow of all 200 radiologists involved. And in these early discussions, it kind of became clear that we needed to address the turf concerns and really try to create equity as best we could across the jobs, knowing that everybody's going to be doing a little bit different job and there's nobody who's going to be equal, but we'll try to make it as fair as possible. And fortunately, a lot of these topics were really well covered in the RLI sessions that I've had through a number of the on-demand and the dedicated programming that the RLI has offered over the years. Talked a little bit about work-life balance earlier. Obviously, one of the successes is we definitely optimized our on-site staffing. We built that around our radiologist preference. We asked them what their preferences were for on-site and off-site shifts. We were able to redistribute 50% of the shifts, and we had a greater than 100% increase in homework site requests. I mean, part of this was because we were in the middle of a pandemic, and I think people saw great value in the optimization, but there's never a bad opportunity to make a good change. And one of the really good things about this, or one of the key takeaways, was we were also able to optimize the on-site workstation needs. And so we've really carried that forward into making sure that we're planning for future growth as in both remote reading and at the hospitals as needed. The next thing that I want to talk about a little bit was just the recognizing the relationship between radiology and overall clinical operations. Prior to our implementation of this, we did have some outpatient turnaround times that were regularly outside of target, despite what we would consider local staffing to provide timely emergency, inpatient, urgent care interpretations. And we were really getting some pushback about how are we going to improve this? And so we took that on as the task and said, with the end result of this was a 35% reduction in turnaround times over just a couple of weeks there, 3 to 4 weeks. It was the first month of the project. We did have an interesting thing that happened after the first month was the initial wave of Omicron, and it had a little impact. But one of those things was because of the scale we had built, we were able to identify that quickly in the daily reports. We were able to operationalize and make changes. And even with some increased sick leave, we were able to rebound very quickly in a way that I don't think would have been possible before all of that work. And finally, we talked a little bit earlier about the businesses must make financial sense, and how do you do that in terms of developing your improvement strategies? Well, one of the things that we wanted to do was pay specific attention to how these would improve the operational finances of the group going forward, while also providing exceptional patient care and improving radiologist well-being. And so one of those things was improving standardization, right? So with the growth of multiple hospital systems, we were having different protocols and different places to find various notes and technology histories and even patient histories and path reports. What we've seen through this project is an increase of protocol standardization going from about 50% to over 80% of all volume now, and only climbing, projected to improve next year again too. And the technologist history standardization was 10 times improved compared to its initial baseline, and just getting that information from the patient to the technologist to the radiologist so that they can provide the best interpretation possible. And a lot of these processes will kind of go on in the future now. So you can see on the right-hand side, this is a projection of our recruiting needs in the future. And all of this data and all of these tools now help to drive the practice to be forward-looking and kind of think about the best ways that we can operationalize our success while also providing work-life balance. And so I think that is going to be my last slide, and I'll turn it over to Dr. Dune, but it was a great project. And I thank RLI for all of the insight and education it provided to help me really take care of this project and see it to the end.
All right, thanks, Andy. Well, thanks for having me. I'm Ryan Dune, and I'm the president of Advanced Radiology Services. And Andy did a great job presenting the specific project that he led. I'll start by just sharing a little bit about kind of who is ARS and why is that project important to us as an entity, right? So Andy mentioned that we were started in 1998 by the merger of two radiology groups. And sometimes you look at the past of how you got where you are, and it tells a lot about where you want to go. And I think we see that in the history of ARS. So those two radiology groups, they merged. They were a group of 10 and 13 at the time. They merged because their hospitals were merging to form a new hospital system called Spectrum Health, which is now Corewell Health. And the radiology group, which is a sizable group at the time in 1998, but certainly small by today's standards, they found really three critical improvements in their model when they went from 10 and 13 to 23. So number one, they were able to be more subspecialized in their approach to radiology, which we still believe really adds tremendous improvements in quality. So subspecialization in radiology we've seen driving quality and improving patient care, and it drives better service levels, right? Whether it's turnaround times or other metrics, other aspects of customer service to our clinicians and our hospitals. That clinical improvement was evident at the start of the very first kind of growth of ARS in 1998. Second, those initial radiologists, they found an improvement in their work-life balance, right? And they are, as a larger group, you're covering less evenings and weekends and off-hour shifts, and all of that adds to sustainability and recruitment and retention, which is obviously a critical challenge for radiology entities around the nation right now. And third, they found some improved financial efficiencies, both at the clinical level, but also in the administrative level. ARS has really been a key part of our growth strategy over the years, has been really those three combinations, those three things: clinical impact, work-life balance, and financial efficiency. They've held true as we've grown over the years, right? We've grown through mergers, through other groups joining us, through new hospitals coming in and asking for us to take on services at their location. Those three critical improvements have held true at each step along the way in our strategic growth. And so the benefits of scale are really key to our strategy, and what we like to offer to our partners, our customers, and our patients is it's 24/7 subspecialized, highest quality care, while maintaining really the local presence, the boots on the ground, so to speak, component of radiology that has been critical to the success of radiologists for decades and decades, right? And we are not a teleradiology company, but our goal is to develop the infrastructure and informational support to be able to supplement and maximize the care that we're able to provide as a private practice on-site radiology group. But we're not a health system, right? We're not a system that has a complete model. We service multiple different health systems, and so one of the key challenges for us in achieving all of those goals through scale is how do we aggregate all of that clinical work into an organized approach, right? So that our neuroradiologists are covering for multiple stroke centers at the same time. And how do we create workflows, both on the IT perspective and then also within like the radiologist's schedule and all of those different factors to be able to do that in a really well-tuned manner. We found that investing in our infrastructure outside of the clinical component, right? So that Andy mentioned STARS and DRARS. Those are, we have 220 physicians, 220 radiologists, about 30 mid-level providers. And then in STARS and DRARS, which are wholly owned subsidiaries of ARS, we have about 180 non-clinical employees. And that 180 employees includes things like billing and finance, accounting, legal, but it also includes a lot of IT support. And what it was kind of unique with, I think, within STARS that you don't see in a lot of other private practices is data scientists and software developers, right? So that we can really use all of those tools to maximize that patient care and that delivery model that is key for us to aggregate across so many different health systems. Andy mentioned decision support, right? That's the component within STARS that really produces these deliverables so that we can be, we talk about evidence-based medicine. What we want to be kind of from the management side within ARS is it's evidence-based management too, right? And so, Andy presented some great slides that how do we take these two silos of large clinical volumes and put them together to really maximize the benefit to the patients and the efficiency to the organization. And it really is a data-driven approach. I guess it's a fantastic tool. We're excited to have it. We're going to keep developing tools like that within ARS. And I think that I certainly encourage others to do the same. But the one thing I'll say, I guess, and I'll close with this and then we'll leave some more time for questions, but great tools like that require users to lead the way, right? So that's where I think the RLI, this is it's a great story of what Dr. Moriarty was able to accomplish within ARS of leadership, utilizing the support and infrastructure that we're able to develop. And with that, I think I'm done. So move on to questions.
Okay, well, first of all, I want to say thank you to our stellar faculty for sharing your inspiring leadership journeys and the impact your initiatives have had. So we're now going to move on to the Q&A session of the webinar. So go ahead and if you have a question, go ahead and click on the Q&A icon, type your question in the window and hit submit, and we'll be able to ask your question for you of the faculty. I do have an initial question to kind of kick things off. This is going to be for the whole group. What do you think was the biggest challenge that you encountered with implementation of your project?
I'll go first, and then I'll turn it over to Vivek, because I think ours was just because it was a very big reworking of what everything was, everything that people were used to doing. And so they had 200 radiologists. They're very accustomed to doing things the way they've learned, as Ryan, Dr. Dune mentioned. Some of those habits had stretched back to 1998, right? And so we come around in 2000 and say, well, we've got a new, better, faster way of doing it. It's going to require some changes and really rich management of getting people to do that. And I remember specifically some lessons from the RLI, which helped bring that home. There was a great talk. I think it was, I forget the author, but it was from Cotter's Principles about how to make that happen. So really getting engagement and buy-in from all of our radiologists was definitely the big challenge.
Dr. Dunn?
Yeah, thanks. I was just going to add to Andy's point. I think that to me, the biggest challenge of these kinds of changes is really cultural and it's personal, right? It's Andy mentioned, I've been doing it this way for X number of years. Why do I have to do it some way different? And I really think that the answer to that actually goes back to a book reference that Vivek made earlier, right? The Simon Sinek and Start With Why. It's a fantastic book. If any of you haven't read it, I would agree with Vivek's recommendation. But that's really, I think, how you get people on board, right? Is share this, let them share the why, right? Not only understanding it, but actually helping to form it. And so for us, there's a very strategic why of it's impacting patient care and it's physician work-life balance and improve financial efficiency. And as people are able to see those three components of why we're making change, that's what really helps to overcome that cultural challenge.
Yeah, I would think, for us, on the front end of it, I think, we actually surprisingly didn't have major obstacles. Like I had said before, Dr. Mulik was very supportive of the project. So, we were able to streamline a lot of the front end bureaucracy and red tape. I think our challenges have come after the completion, and some of it is growing pains. Some of it is kind of understanding the costs. We did put a lot of money into the infrastructure, into the equipment, and just kind of balancing, our payer mix with generating the revenue, with balancing the expectations of what we sold to our service lines, breast surgery, IR, and just meeting some of those challenges. I think we've done a very good job to date. We do have some more growing challenges and some cost efficiencies that we probably have to match up with. But I would say for us, because we came out of the gun so quickly and we did it so efficiently, I'd say our challenges were kind of after the fact.
Yes, I'll agree with Vivek. And our problems, mostly our problems, we call them, our challenges mostly arose after the center was set up. My first, of course, challenge was to see if my team can deliver. This was one of the first few projects that we started, and we have had a ton of projects after that. We have a Center for Personalized Medicine. We have an Innovation Center, Research Institute, Rothman Orthopedics, Colorectal. In 2.5 years, we have about 14 new initiatives. But this was the first one. And I wanted to see whether the team responds. You give a stimulus and you see how much team can perform, and they did a fabulous job. But getting the word out, and also we are not an outpatient center. Jersey works in a very strange way. The referral patterns are, there's only something that I don't even think God can predict. But what happens is that we have seen there are already fixed patterns of how patients go to easily accessible centers, though our reading probably could be is probably better, and we do great service. But getting the word out was very difficult. And then, of course, once the word started getting out, the volume started picking up. And then we needed Dr. Mason and his team to start reading more images. So he probably got the trouble onto himself, but it was worth the effort. But these are the typical challenges. Like marketing is not a very strong suit amongst physicians and hospitals. That only happens when you become like a Dr. Dunn and you have your own business, and then you start getting wise. And the easiest thing was me being able to do this stuff. As chairman of surgery and CMO and chairman of cardiac surgery, I could not even get a secretary or a statistician. As a CEO, it's so easy to get, get it done. It's done. So there are a lot of blessings, but financial challenges will come later if they don't perform. But right now, we are overcoming most of the challenges.
Any other comments? Next question. What would you have done differently?
Should we start from me?
Yeah, sure.
Okay. What could we have done differently? I think we should have started with spreading the message more aggressively as the project was taking on. And keeping an equipment around not with a suboptimal utilization is not perfect. However, I think also we are transitioning from a for-profit to a non-profit system. This is one of the largest systems in the country that is undergoing this way. Normally it goes the other way around. And so as we are doing this, and we are also out of network, so we are going in network. So our charge masters had to be changed. There's a whole bunch of stuff, the technical stuff that needed to be done. We could have worked a bit earlier on that, but since this was right at the time when I took over, next time around, the next few projects we've gotten smarter. But I think we should have worked on some of those stuff, including getting the word out. Other than that, I think it's gone on very well. I was very impressed by the ingenuity of Dr. Mason and his team. And actually all the staff people did the interior design and decoration of the suite, which is really beautiful. So I must commend them for that.
Any other comments about what you would do differently?
I think for ours, I mean, we've seen such a great benefit that the only thing I wish that we would have done earlier is I started sooner, right? And maybe it wasn't for lack of trying, or it wasn't for the ability to get it done. But if we could have moved it up, if we could have engaged the stakeholders earlier on and been more persuasive to make that change earlier, I think it would have just been a longer time that we've had those benefits.
Yeah, from my end, I think I'm very happy with the speed at which we took place. So, I don't have any regrets, and like anything else, there is a learning curve. So I'm happy that we are adjusting now, and I think there's utility in the learning after the fact as well.
Yeah, it's a great question. What would you do different? I mean, and I think what I struggle with is that the outcome has been so great that there's a little bit of hesitation to change anything. But if I had to think of something we could have done better, it would go back to that cultural part I was talking about before. I think that if we, it's really hard to we're a private practice, so we're a physician-owned partnership, and so to get the partners that 150 or so partners kind of bought into the process, we could have done maybe a little bit better job of that. Certainly it wasn't because of lack of trying, but if I could have figured out a better way to do it, I guess that would be something that we could do better.
Any other comments? So my next question is for Doctors Mason and Malik. Can you touch upon some barriers to healthcare access unique to urban and inner city communities?
So I think one of the challenges is, like Dr. Malik was talking about, is a lot of the advanced care services are not offered within a reasonable distance. We do live in the kind of shadows of Manhattan and affluent suburban populations on the New Jersey side, but for a lot of our patients, being able to travel takes time, and they're living paycheck to paycheck. So when you're living paycheck to paycheck and a couple of hours or a day's wages are lost, particularly in this time of inflation and rising food costs and housing costs, we were very sensitive of that, and we are sensitive of that. And that's why, having the facilities centralized, having the access to surgical care where we can coordinate appointments, or having access to infusion or oncological care, those are something that we feel will minimize those costs for those patients. When you have these centers like this, these deserts almost, bringing the care that you would get, from a Rothman Institute that would exist only in Philadelphia, or if you get, Columbia University's, physicians and surgeons performing colorectal and endocrine surgeries, and having them be able to consult with us right then and there. I think that makes a huge difference to our patient base.
Any other comments?
I do agree with Vivek, and very well said. The other issues that I think there's a little bit of a disconnect between the people developing solutions for the community and the community. Though our community, the people who need care are usually, a lot of them are indigent. We are one of the few hospitals that still have charity care clinics that are open, and which allows, it is a burden to the system, and also it's difficult to communicate to them. So until we create a database and a support system, like, for example, it takes sometimes a village to take care of a patient, right? So we are in a situation in which the people who need care most have least access, not because of proximity sometimes. It's just the way to get in. We think that everybody has a smartphone. They do. This is for the people where the payer mix is great. Everybody has a smartphone, and you can send them a message. You can actually have a QR code. We have QR code in our system. However, the important thing is transferring the message to them, and this can happen only through community involvement, spreading the message through local cable news and other stuff, that to tell them that these services are available. And I can guarantee you, even people living 1 mile from CarePoint Health systems some of them do not know that these women's pavilions women's pavilion for healthcare exists there. So it's somehow it has to go down to a grassroots level through social workers, through community leaders to spread the news. And that is going to be one of the major challenges because the glitzy, digital media and all does not go down to the people who need it most. It is through word of mouth, through communities, so actions, through local politicians who really care. We have a Union City Senator, I'll give him a shout out. He really cares about his people. However, most of the clinics and urgent cares there were taken out because they're not generating enough revenue. We have decided to go the other way around and have one there. And I mean, maybe a bad decision in the long run, but you have to provide care to the most indigent. So I think it's a question of the triangle of health. You talk of cost, quality, and access. The quality is never been defined, excepting in probably in radiology. It's insurance companies take it separately. It's just more about cost. Access becomes the most important thing, and access that too is not just finding on a website, clicking in a hospital, making a phone call. It's a two-way access. How you gain access to the patient and vice versa. So that is something we are diligently working on our population health innovation tools that we are creating to create a 360-degree communication with the patient, families as well through the hospitals, care managers, and the society in general. So I think that's a very important aspect.
Any other comments? Okay, so I have one final question here. So this is for Doctors Moriarty and Dune. So you both mentioned how recruitment and retention have improved as a result of this project. Could you expand a little bit on that and what specifically this project brought into your practice that made it more attractive?
I'll start. I'll turn it over to Dr. Dune. I mean, one of the key goals was obviously operational efficiency, and one of the benefits we found from that was in polling our radiologists, we really were able to ask people what their specific ideal job would look like. And so we have a yearly update to not only the physician skill sets, but the desired amount of work and in which clinical sections. And really, we're trending toward what time of day and what kind of shifts. And so I think offering the maximum amount of flexibility gives the radiologist sort of the greatest long-term work-life balance and is an important sort of retention tool and hopefully a recruitment tool. But I'm interested to see what Ryan has to say about that.
No, I agree with that, Andy. I mean, I think what it really comes down to is that it gets back to that really large scale that we're trying to develop so that both the radiologists and the patients share a benefit, right? I mean, we're able to create a large enough clinical model and a large enough clinical scale by aggregating across multiple healthcare systems so that our patients who might be at smaller rural hospitals are getting their brain MRs read by neuroradiologists, right, by subspecialists, and that's better for the patients, but also we're able to offer to our recruits and to our existing radiologists for retention that, what we see in the job market is the two kind of most common desires are time spent within their subspecialty. People coming out of fellowship want to spend as much time as possible in their fellowship training area, and also flexibility with their work-life balance. So we've been able to use that really large scale to offer them really large degrees of time within their subspecialty, and also it's pretty much you name your work-life balance, right? If you want to make a lot of money and work a lot more, that's an option. And if you want to have a daytime only job that and work less, that's an option too. You have people who can work more weekends, less weekends. All of those things are possible because of this large scale, and then the data-driven infrastructure that really supports it and is being making sure that we have the staffing necessary to meet the patient needs.
Perfect. Any other comments?
Well, I just add to what Dr. Dunn was saying. As a cardiothoracic surgeon, we never talked about work-life balance in the past. But post-COVID, I in the seminar in the Thoracic Society meeting, I asked them, what is job satisfaction? You know, and and I made a formula up, which of course was directly proportional to the amount of money you can make and divided by stress, right? And work-life balance became a very important portion. So I told them the fact that then I showed them a graph, which showed a graph of investment bankers versus thoracic surgeons. So and I said, now that you cannot make that much money to be happy, you have to manage your work-life balance to decrease your stress. So I think so it's very important that people have to start focusing on the work-life balance aspect of it. And I mean, people are still scared to tell me about work-life balance in the workplace, but I think it's important that we focus on the work-life balance aspect of it for, especially in this day and age. And COVID is going to be 2 decades probably of the after effect of what happened. And I think radiologists were the best suited for COVID because you already were in dark rooms, isolated, reading images. But for the rest of the people, I think we have a lot of catching up to do. So that's my comment. Unsolicited, but that's my comment for this.
Perfect. Any other comments? All right. So with that, I think we'll conclude the webinar and I will go ahead and turn things over to Dr. Pyatt.
Thank you, Jen. Well, first, on behalf of Jen and I, we would like to express our profound gratitude to our award-winning faculty tonight for sharing your stories, your successes, your challenges, your wisdom. Thank you for all of that great information to our audience this evening. We also want to thank our audience for attending this evening and participating in the program. And we'd like to have your feedback. So please share your feedback with us. You'll be getting a survey here soon in the next week. And the recording of tonight's program will be available in the next week. The next Power Hour topic will be Leadership is for Everyone. And this will be held on Tuesday, January 10th, 2023 at 7 p.m., 7 to 8:30 p.m. And you can register for this program and other upcoming RLI Power Hour webinars at acr.org/powerhour. Again, thank you, everyone, and a special thanks to our really fine faculty this evening. Good night, everyone.